right, well, thank you everybody for attending Journal Club. It's great to see so many people. Um, I first want to thank Lizzie for helping with creating the slides for today. And I hope everybody enjoyed the article. And thank you so much for you all picking out the journal article. And I guess my first question for everyone is there anybody who was an author on this article, which came from Rwanda, in the audience today? Raise your hand if you were involved in this project at all. I was just curious when I read it. No? Okay. I was just wondering whether there was anybody who had any, personal experience with this project. Okay, excellent. So I hope everybody enjoyed it. I certainly enjoyed reading it. It was nice to read something that came specifically from Rwanda, and I hope everybody will enjoy talking about this article. So we'll go ahead and get started. And as we've done before, I will go ahead and summarize the article in the slides, and then I'm hoping that you all will jump in and comment on the different sections and share your thoughts and your feelings about what went through your mind when you were reading this article. Are you able to hear me okay?
Yes.
Yes, okay, great. All right, so the article starts out in the introduction talking about the gap in client knowledge regarding LARC. They talk about the unmet need for contraception in Rwanda being 20%, and that 47% of Rwandan women do not seek to have more children. They comment that community health workers, that they abbreviate as CHWs throughout the article, have a central role in Rwanda's family planning policy. And some of the obstacles to the uptake of LARC from the client side include a lack of familiarity with LARC methods, misconceptions about safety and efficacy, and then the non-involvement of male partners. In the introduction, they also talk about a gap in provider knowledge, which includes provider bias being a significant barrier to the provision of all of the LARC services. And they talk about the lack of knowledge on how to insert the LARCs and a lack of time to insert LARCs during family planning visits. They talk about that since 2009, government clinics are receiving training in copper IUDs as well as implants in terms of insertion and removal, but that these activities, placing copper IUDs and the implants, are not a service that are performed by the community health workers. These are performed by other providers. So that there still had been a very low uptake, with only 0.7% of women using IUDs and 4.7% using implants by Rwandan women between 2014 and 2015. So they had implemented a program where Kigali community health workers had assumed the responsibility to provide oral contraceptive pills and injections to the community, and then they added a training program in which they learned about LARC methods and family planning counseling, particularly couples counseling. And so they added this to the work of the community health workers. And this paper, the purpose of the study is to assess the results of a program that included fertility goal-based and couple-focused family planning counseling delivered by the community health workers. coupled with LARC training and support of nursing staff at the clinics where they were putting in those LARCs. And the fertility goal-based counseling, they define as counseling that includes attention to short-term, medium-term, and long-term fertility goals. So that was the purpose of the study. So why don't we just stop for a second, talk about that introduction, and just comment on what do people think about that background? Does it clarify for you what the gap of knowledge is and the questions being asked? Does the study purpose seem reasonable and clearly stated? Is there any comparison, and is it stated? And can you tell what the hypothesis is for this particular study? Or anything else that you want to comment on the introduction? Do you feel like you have a clear understanding of the reason for the study? Does it make sense to you? I know we planted somebody out there to comment on the introduction. What are your thoughts?
Hello, this is Manfik from CHW.
Yes.
Yes, my quick snapshot of the study, I was thinking that though the 20% was stated as the unmet need on family planning, does not necessarily mean that it is from the married couples or the couples that are partners, that's known partners. So it did not go through to say that probably these 20% are people that, let's say, women themselves that are having unmet needs, not necessarily that are having partners. So the study itself being set basing on the fertility goals, it can actually take out a big percentage of people who could have unmet need and still they are not coupled, they are not with partners. So that was one of my first quick view on this. Thank you.
So the unmet need could be even larger, is what you're saying?
Yeah, it could be larger. And we probably could be just addressing a small portion of the population when probably the bigger other people that could not have even the goals for fertility, they are just having unmet need, but they are not into the population. So that was the first snapshot idea that I got.
Okay, yeah, a good point. Any other thoughts?
This is Sashka Orange. Another idea is the unmet need is not 20%, is 19%. Maybe it's a mistake. They can collect it if possible. According to DHS, it's 19%, not 20%. Thank you.
Okay, thank you.
Hello.
Did you feel like you could tell what the hypothesis was for this study?
Here at Kiremera, we want to give comments regarding the introduction.
I'm sorry, we can't hear. I apologize.
Richard, could you turn up your volume a little bit?
No, it is on.
Or maybe speak closer.
Are you getting me? Are you getting me?
It's very low.
Yeah, I tried to increase the voice. I was saying that on introduction they used DHS 2015 data, but they should also consult the current report. the current Ministry of Health report, because 20% of animated meat is still high. So since the article is very current, they should use the very updated data from the Ministry of Health, because the last DHS was done in 2015. So that is a gap. Regarding the study purpose, it is a reasonable and clear. They clearly stated the purpose, and it is reasonable and researchable. Regarding whether they compared what they said, their hypothesis is evident, but they did a wrong hypothesis. It is too long, because I saw they did 3 hypotheses, and to reach 3 hypotheses is somehow difficult. That can bias their results. Thank you.
Thank you. All right, we're going to go ahead and move on. The next section is the methods design. So this is a pre-implementation and post-implementation study. So they look at data from before they made these changes and after these changes. And the setting is 8 outpatient family planning clinics in Kigali, Rwanda, from August 2015 to September 2016. The population is Rwandan women living in Kigali and receiving the family planning services from the community health workers. And then the content of the family planning counseling, the couples family planning counseling, was delivered by the community health workers. It was developed by multiple stakeholders. The clients were educated on all of the family planning methods available. And as I said, they used fertility goal-based counseling to identify women and couples wishing to delay conception for at least 2 years, and would allow couples to discuss their fertility, their family planning goals. So the community health workers received additional training in LARC methods, the importance of counseling both the man and the woman together, and the importance of counseling based on the fertility intentions. And the community health workers leveraged the networks, the rapport within the community to approach the most likely potential clients. And then after the counseling, the women were given written referrals to the clinics. The referrals never expired. They included the community health workers' ID and the date of issue. And they did limit the number of referrals to balance out the supply and the demand. Prior to the community health worker creating this demand for more placement of LARCs, they had training for placement and who was eligible for placement for nursing staff. There was didactic resources based on those that were provided by the Ministry of Health of Rwanda. There was coordination between the community for the demand that they would be creating for LARCs and the government clinic supply. They negotiated with providers to ensure that there was adequate supplies and equipment. There were regular meetings between the clinic nurses and the community health workers. As the demand increased for LARC placement, the clinic capacity increased with a scale up and with supplemental staffing and support for the increased LARC placements. So they were coordinating so that the supply never overwhelmed the demand for LARC, and they ensured that the community health worker and nurse capacity both grew over time. For data recording and extraction, they recorded the community health worker referrals and the resulting family planning clinic visits. They used a contraceptive recording from the log books of what they ultimately chose. They collected demographic information of the clients at the clinics, including education level, religion, marital status, number of living and desired children, the current family planning method that they were using when they came to the clinic, and then the type of counseling they received, either couples counseling or if they were there by themselves, the regular family planning counseling. And then the data was initially entered into log books and then later put into Microsoft Access. So then they also were going to compare the data that they were collecting with this implementation to pre-implementation data. So they used clinic records from August 2014 to 15 to use for comparison. And one clinic did not have these records. That was excluded from the analysis. So they did a pre versus post comparison overall, then also by method selected and by health clinic specifically. And they used two-tailed paired t-tests in SAS, and they used p less than 0.5 for all tests as significance. They looked at the client demographics and how those correlated with LARC uptake. The demographic data was described using counts and percentages, or means and standard deviations for categorical and continuous variables. They used chi-square and t-tests to evaluate the differences. The women were characterized into those who were LARC uptakers and those who were non-LARC uptakers. And then they looked at how the demographics were associated with LARC, IUD, and implant uptake. And they looked at each of those versus non-LARC. And then they also looked at the two LARC against each other in bivariate analyses and also in multivariate logistic regression models. So first of all, let's comment on the methods. For this type of project, looking at a program evaluation, does this method seem appropriate? Does it seem like something you'd be able to look at these results and then generalize this to your women or women in other countries? Do the outcome measures that they are looking at, which are uptake of LARCs, ideal measures, and then in their methodology, are there things that they did that would reduce bias? Do you see things like follow-up? Are there any things that you would want to comment on regarding the methods? Who do we have planted out there to comment on methods?
Yes, sure. Can you hear us?
Yep.
Yes?
Good. We would like to approach the study, first of all, by the way, actually, we've done a bit of methods, kind of scanning, and we think they had one side where they were comparing the training given to community health workers, where they can prompt a result of where the population are going to uptake the long-acting reverse contraceptive methods. So that's kind of how we're looking at it. And we think their method, of course, was to introduce, as you said, to give this training to the community health workers, and then the training, of course, which was transmitted through the counseling, and then, of course, which would influence later on the uptake on the long-acting reversible contraceptive methods. But we've seen one of the things that we've come up with these people, they have put in another confounding element that we think could actually change a lot and even change the uptake itself and influence the outcome. For example, they are giving 0.64 or not 63 USDs per person, which is another major influencer of which people could uptake the method, not because they were canceled, but because the money, like the health worker the health worker incentive could be probably the most motivator rather than the training itself. That's one. Secondly, they talk about the training is talking mainly about long-acting possible contraceptive methods, and we're not seeing other methods. And we know that in the family planning package, the client choice is already the right one. So we think this was kind of a biased training or probably a method or how they put it up, because we don't see them training the full package and then the idea of where the patient or the client was able to choose which method in the end. But you are looking at them training about LARC and the patient getting it and the outcomes and of course the transfers and everything that is stated in the study, but you're not looking at the whole picture. So we don't know exactly if the community health workers were taught on this method only to go and tell people about long-acting reversible contraceptive methods. And of course, we're not seeing any randomization or blinding efforts. Blinding methods. Those are the first insights from us. Maybe as others push towards some other thoughts, we're going to discuss more. Thank you.
Thank you. Yeah, excellent points. Any other comments?
Comment is always about this is Yashka. We're talking about methods. And,
methods.
The randomization. There is no clear method used to allocate those clients, subjects in two groups. One, there is no randomization and there is no blinding, which could be a very big source of bias. So this also is something that you can critique. Then the follow-up of those women who took the family planning methods, they are not clear. Maybe tomorrow, after tomorrow, they got some adverse events and there's no one to follow up it. So I would like to get maybe more explanation on that.
Yeah, it's a good point. They don't provide any follow-up on whether women were satisfied with the ultimate choice that they made. Yeah, and I agree. It was hard to tell how women ultimately got selected for receiving the voucher to go to the clinic. Yeah, that's a good point. Okay, any questions on the statistics? So it's a little bit harder on these program evaluations because there's not really a power analysis that's given or even a sort of in retrospect analysis to let you know what you had the power to evaluate. But do the statistics that they plan to do appropriately address the questions being asked? Do the groupings make sense, the way they set them up, the LARCs and the non-LARCs? And the exclusions that they make are really, do you see any exclusions factors described within the statistical analyses? Did anybody have any concerns about the statistics plan? The only real exclusion I saw was that they were going to leave out one site from the pre-implementation evaluation because they didn't have any data on them. I wasn't sure how that exactly was going to impact the analyses. Okay, we can go ahead and go on. So for the results, for the community health workers referrals and LARC insertions, there were 184 community health workers that issued 7,712 referrals. There were 6,072 family planning clinic visits to the 8 participating clinics. So overall, that was a 78.7% referral uptake. LARC insertions increased over time from 39 in the first month, peaking to 649 in August of 2016. And then the average time between receiving a referral and getting to the clinic was 5.5 days. So that was really quick. They were able to accommodate the women very quickly. This diagram is from the paper and shows the blue line is the LARC insertions and the red line is the referrals being issued. So you can see they were able to keep that, they're probably able to meet the need that matched the referrals pretty well across time, and you can see it going up consistently. And then in terms of comparing the LARC uptake pre and post the implementation, 7 clinics had comparable data that they could look at. They did have a statistically significant increase in LARC uptake pre and post implementation. The monthly average for IUD insertion increased from 26 to 61. That was significant. The monthly average for implant insertion increased from 109 to 309, and that was significant as well. And then looking at it by individual clinic, 6 of the clinics significantly increased their monthly implant insertion, and 2 significantly increased their IUD insertions. And this, again, shows you the LARC total in gray, and the implant is in blue, and you can see that most of the increase is in the implants. The IUD has increased as well, but most of the increase in the LARC is from implants. So looking at the client demographics who received the couples family planning counseling, of the 6,072 clinic visits, 5,743 or 94.6% were LARC uptakers. Implant was most popular, as I showed you. That was 83.6%. And then 16.4% chose the IUD. And they pointed out that of those who were LARC uptakers, a higher percent received the couples counseling compared to those who did not receive LARCs. They were non-LARC uptakers. They had a lower percent that received the couples family planning counseling. They had more individual family planning counseling. The average age was 28. Educational rates, 63% primary education, 29% secondary education, and they commented that the IUD recipients were more likely to have secondary or higher education compared to implant or non-LARC uptakers. 50% were Protestant, 43% were Catholic, and a higher proportion of non-Christians were in the non-LARC group. The highest proportion of Catholics were among the IUD uptakers.
Can I just stop you for a second? So I know I was speaking with Alice. I know that some of you have meetings that you need to get to now. So please, if don't let us keep you if you need to go. That is okay. For everybody else that would like to stay, we'll finish. We're making a recording, and so what you miss, you can go back and view.
Yes, absolutely. And then in continued client demographics among the individuals who had the family planning counseling, most were married, 48%, or in traditional cohabitation, 44%. The IUD group had the highest proportion of legal marriages, 60%, compared to the other groups. In the non-LARC group, they had the fewer living children than the LARC group. Within LARC group, the IUD users wanted fewer children than the implant group. And the current reported contraceptive methods reported at the clinic, so the method that they were using when they walked in for their to discuss using LARC were injectable oral contraceptive pills, implant, IUD. The non-LARC users were more likely to currently use either an oral contraceptive pill or injectable. LARC, the people who came in and got LARC were more likely to be currently using condoms, and all but one of the 242 women that were currently using LARC continued using another LARC product or the same one. This is the data that we just went over, and I realize you can't see that very well, so we're going to skip it. And then for the multivariate analysis of the predictors of choosing an IUD and or an implant, when they compared LARC versus non-LARC uptake, they found that referrals issued to couple. Let me just look at this again. If a woman, if you came as a couple versus a woman alone for counseling, you were more likely to choose a LARC. Protestant, Catholics, and Muslims were more likely to choose a LARC versus no religion. Women having more living children were more likely to choose LARC. Women desiring fewer children were less likely to choose LARC. And then for the continued multivariate analysis of IUD uptake, specifically IUD uptake versus non-LARC. For IUD, the predictors stayed the same, except current LARC use and religious affiliation was no longer significant. But if you had secondary education, you were more likely to choose an IUD. So more education, more likely to choose an IUD. Being married or cohabitating, you're more likely to choose an IUD versus non-LARC. Specifically for the implant, the predictors were similar, but if you had secondary educations or higher education, you were less likely to choose the implant. And then when you were comparing the IUD and the implant against each other, if you came as a couple versus a woman alone for counseling, you were more likely to choose the IUD. If you had more secondary education, higher education, you were more likely to choose the IUD. If you were married or cohabitating, you were more likely to choose the IUD than the implant. If you were Protestant or Catholic, you were less likely to choose the IUD. If you want fewer children, you were less likely to choose the IUD. And if you previously had a LARC, you were less likely to choose the IUD. And again, this is the data that's in the paper, but it's too small to read. Okay, so those were the results. So they looked at the demographics, and then they looked at predictors of choosing a LARC, and then they looked specifically at choosing IUD or choosing implant, and then they looked at the predictors of choosing between those two. So what do you think about the results? Is a primary question answered by this research? Were the results presented to you in a way that was logical and understandable? And were there any other data analysis that you think would enhance this research or would help answer the questions for you? It definitely gave a lot of data.
This is CHW.
Yes.
So the primary question, I think, was answered as the results as statistically significant. But secondly, there is the need of another study to validate this one.
Thank you. Was there anything else that you would like to see from the results?
So we don't know, rather we think of biases, like we don't know if they were influenced by factors like incentives that could cause referrals.
Yes. Could you tell whether the women clients were receiving an incentive also?
We are not sure. According to the article,
I couldn't tell either.
They didn't tell us. We only know from the healthcare providers.
Did any of the results surprise you?
There is a significant increase from 9 to 64. But I need to know if that the adherence to this, or if there is a continuum of this uptake in subsequent months.
Mm-hmm. So whether it was sustainable without.
Yeah, exactly.
Mm-hmm.
And what about other methods that are not long acting? I think they need to be compared. What could be the reason of the choice?
Yes, because it sounds like they, at the counseling, they picked out the women who they thought would be appropriate and sent them over. So we didn't really hear about the other women or how many there were or any details about that.
Yeah.
or whether all of the family planning methods went up, you know? We didn't hear about any of that.
Yeah. Actually, it was opted out. What was their choice? Was it short acting?
Yes. Right. Whether the absolute number went up, or whether this was the percentage also went up. Yeah. Okay. Let's go to the discussion. So they comment initially that the couples family planning counseling coordinated with community health workers and clinical nurses in government clinics was associated with rapid, substantial increase in LARC uptake. Aspects of this implementation have been tried before in other studies with similar results. There is a community health worker referral system in Uganda. Male partner participation has been shown to be helpful in Ethiopia, Malawi, Ghana. They report from the literature that any religious association showed increased likelihood of implant uptake, even Catholicism, in their data, which was surprising and encouraging. And they also found that choosing an implant was associated with little education compared, and with an IUD, higher education was associated with choosing an IUD. And other studies correlate higher education with LARC uptake, but have not compared implant versus IUD. So this was a little bit different, because in this study they found that the IUD was associated with higher, but implant was associated with lower education levels. And considering that they had mostly implant insertions, overall, I would imagine their LARC uptake has to be associated with lower education. So this is they really did find something that was a little bit different from the literature in Rwanda. What do you all think about that? The education level association with LARC uptake and its difference for IUD being associated with high education and implant being associated with lower education. Do you notice the same thing?
Yes, this is from Sashika. So we noticed that they controlled the outputs against the social demographics instead of looking at how did the social demographics affect the outcome. So, and consequently, we don't know if, in case you wanted to educate the population, should we educate those who have implants, or should we educate those who are Catholics? If it makes sense.
Okay.
And this is from CHW.
Yes.
So this could be because the IUD mechanism is easy to explain to the client compared to physiological action or mechanisms of hormonal implants.
Mm-hmm. That's a good point. Okay, they also point out some things that are consistent with the literature, such as having more children, wanting fewer are associated with LARC uptake, which they found current LARC users likely to continue using LARC is in the literature, and they found IUD users are more likely to be married and cohabitating, which is in the literature, and they found a preference for implant over IUD has been found in multiple sub-Saharan African nations, and the potential for integrating family planning services with HIV services, which they talked about at the beginning of the study and has been done in multiple other studies as well. So there were several things that they found that are consistent with the literature. And then they talked about their limitations, that there's no data on reasons for non-LARC uptake. There can be misclassification with self-reported client data. Clinic selection is not representative or generalizable. The potential for missing demographic data from the logbooks. They didn't use other clinics as controls during the implementation. Instead, they used pre-implementation data. And they said that they used that because they were trying to minimize influencing factors from other clinics. Any other limitations besides the ones that we've already mentioned that you would suggest?
I know somebody mentioned this already, but they didn't talk a whole lot about their potential issues with follow-up and the fact that, we don't know how many women had their implants or IUDs removed early or, other things like that.
Right. And as was also mentioned, the sustainability of the program. So we always like to ask at the end, the clinical context. How can we apply this to our care of women locally? Is there anything we want to change in how we currently practice? Is this anything that would influence, what we do? Is there any research project that you would want to do to see how this might work in your context? What do you think about this for yourselves?
This is Yashibe again.
Yes.
So I think there is increased uptake of long-acting reversible contraceptives when there is counseling of the couple, which is not a common practice in our settings. Maybe we can start doing that to enhance the uptake, as the study has revealed.
Mm-hmm.
And more trainings as continuous training and follow-up.
I'm in agreement with the people who've done the study that counseling might be the ideal point to go around when we want to get people. When we want our population to understand about the LAC. But I would say that if we want to get enough evidence, we need to minimize the biases and the confounders. Because in my understanding, I think the incentive issues has contributed a lot to the benefits and to the larger results that we've seen. Not necessarily that was the counseling. So I think if we are to improve, what we can get from here is to counsel population on the long-acting reversible methods, but also try to minimize these sort of incentives when we are trying to get evidences that are going to be applied in our different settings. Because once a healthcare provider, you've already put something in there on their way, you've already set something in their way like money incentive, it is going to be quite, biased in sort of how much counseling we are giving and how much are we pushing the clients to get a certain method. And we kind of compromising the autonomy and the choices of the clients in this way. So I feel counseling is ideal. We should be counseling the clients about it, and I really, really support, but also trying to put in an incentive, a money incentive. I think if we go back to these centers, we might not see exactly the same number of people that are getting this kind of a method. So to kind of just be conscious when you're kind of doing this kind of research.
Yeah. Yeah, I think that's a great point. And it's always a little bit harder when you set things up as a program and then you go back and try to evaluate it. Sometimes you don't have things set up ideally for research, so you have to think about those things ahead of time when you're setting up the program. That that if you want to evaluate it, you have to be really thinking about all those variables as well at the beginning. So that was a great point. Great. Are there any other comments? I know it's been about an hour. Are there any comments in the?
We've had a lot of people commenting throughout. The latest one talks about the findings and the discussion being misleading. Planning to see the effect of CHW implementation program on long-term utilization of family planning devices, but discuss the effects of demographics on those methods and repeat the same information in the discussion. I'm not sure what people think about that. Another person was asking, who is the trainer for the CHWs?
Oh yeah, that was not mentioned. That's true.
Yeah. Somebody asked about the time interval between pre and post implementation evaluation tests. Somebody also mentioned that that not only were at the same time that these community health workers are going out and doing these counselings, there's also media influence and educational promotional things going on, and wondering about how to control for that.
Yeah, so that's a really good point, is that when you do things pre and post, there are many other things that change in time, and that's one of the arguments for, instead of doing pre and post, looking at other hospitals as your control and comparing them to the site that you implement the program at, rather than doing pre and post, because of all the other things that can change at the same time, like media and government policies and other programs in the area. So yeah, that's a great.
Yeah. Somebody else was wondering about the actual operational definition of community health worker in this context, because I think that there's kind of a wide range of education level and training and things like that.
Yeah, that's another really good point that was not provided.
Search again.
the definition of health worker and the education level for training was not provided in the paper.
Right. Actually, when it comes to community health workers in our context here in Rwanda, we do not assume that these people have undergone a certain level of training. Rather, the primary level is the minimum, but it can be anything. Someone can be, most of them actually at a primary level training, and it can actually go to a different level. Some of them have gone to high school, very few of them, but I guess none has reached to a point of university, but they might be, mainly in the cities. But so many of them are just at the level of primary and probably early high school training. So I think they assume that is like a known fact because it's common to have, that's exactly the level of training of so many community health workers around the country. And one more comment before probably I switch on, I mute myself again. Sashka, I wanted to say that this leaves us with a room of research, to open up research, probably to kind of navigate through this, not exactly the same kind of data that we would want to see, but we've mainly in our sites, I mean here, Sashi, Shashi, Rwamagana, and other sites, we've been doing this, we've been having this project and trying to educate our patients on non-contraceptive methods. I think probably it's high time that we start looking at our own data and see how good are we doing in terms of varieties of family planning uptake, and mainly the long-acting contraception, because I feel like we've gathered enough or a minimum of data that would mean something to us already to see if we need to spike the motive and if we need to go higher or change anything, or I think would give us some good thought. Thank you.
Thank you.
Anybody else?
Are there any other comments? Okay, well, thank you so much for joining today. It's been a lot of fun today, and I really appreciate having an article from Rwanda. It's been a lot of fun learning things about how things are practiced in Rwanda, and really appreciate having your input and learning from all of you.
Yes, just a small comment. Just a small comment to everybody.
Okay.
Unless they have gone. They are not listening. Hello?
Yeah, I'm not sure where this sound is coming
Or, I don't know if they are really listening, but when it comes to journal club assessment or reading or doing, people have to read the journal and try to answer questions, not to give their individual, how do you call it? It's about a research. It's about what has been already done. So to see if what was done was correctly done. So it's about assessing. So I urge all the residents to read about how to do a journal club. They have to read first very well the study, part by part, starting with the methods, the result, then to assess and to discuss about it. It's not about changing the study.
Exactly. Thank you.
All right, I hope they understood. I think next time we can do it better. And I think Polyfill has disseminated the topic of how to assess a journal actually.
Oh, fantastic.
Great.
All right. Thanks a lot.
Thank you.
Thank you, everybody. We will have the recording and the slides sent out. Daniel will send those out in an email blast. We will also have a feedback form that we would love it if everybody could take 3 minutes to fill that out. But you will get those follow-up emails shortly.
Have a great day.
Thank you all so much.
All right, thank you very much too.